Well, we've known from findings from the DRCR Retina Network on how to manage patients with diabetic macular edema if visual acuity is 20/32 or worse. In our protocol T, we found out that for visual acuity of 20/32 to 20/40, you can really use any of the anti-VEGF agents and get similar results. However, if visual acuity is 20/50 or worse, aflibercept was better than the others. In this past year, we've published protocol V results. And in that protocol, we looked at, in particular, eyes that were 20/25 visual acuity or better. There really had been no previous study looking at those eyes. So if we focus on those eyes with 20/25 visual acuity or better, and in fact, in real life, that probably extends to eyes perhaps that are even 20/30, for instance, because we generally do not do detailed refraction on all patients that come in our clinic. So we're talking about those patients, as you mentioned, with better vision in that range. And there, we really could use one of three different treatment approaches. One is we can just observe them. A second would be laser photocoagulation. And then a third is anti-VEGF injection. And so we looked at protocol V on how we should look at those three different treatment strategies in treatment of diabetic macular edema in these eyes with better visual acuity. So in protocol V, eyes had to have visual acuity best corrected at 20/25 or better and had to have significant center-involved diabetic macular edema. We then had three different treatment strategies, either initial observation, initial treatment with focal laser treatment, and then or initial anti-VEGF, in particular aflibercept. In the eyes that had just observation or laser, we began anti-VEGF injection with aflibercept if the visual acuity dropped by 10 or more letters at one visit or 5 to 9 letters at 2 consecutive visits. And then they were given aflibercept monthly on a standard treatment protocol. What we found was that after 2 years, there was no difference in our primary outcome, which was loss of 5 or more letters overall. And in fact, all eyes measured 20/20 on average at the end of 2 years. There were a higher percentage of eyes that were 20/20 in those eyes that got aflibercept compared to the other groups, and statistically significant compared to observation. However, if we look at how many eyes ended up 20/25, it was a similar percentage across all groups. So what we concluded was that observation is a reasonable approach, and then, but the patients have to be followed closely, because if that visual acuity did drop, you want to initiate anti-VEGF therapy. You can also use focal laser treatment, and I use it, for instance, if there is a more focal type of diabetic macular edema where laser could be delivered directly. And then the one thing we found there is that you can delay the need for anti-VEGF injections for some amount of time if you use focal laser. So I had mentioned protocol T and then protocol V. Now we also looked at proliferative diabetic retinopathy and its management. That's protocol S. And we recently published 5-year results there. And what we found was that anti-VEGF injection versus pan-retinal photocoagulation are both reasonable treatment approaches. There were some benefits to anti-VEGF injection, for instance, a smaller percentage that developed diabetic macular edema, less visual field loss, less need for vitrectomy. However, there is risk in following patients adequately if they're only treated with anti-VEGF injections. We had, after 5 years, we had only 60% of patients come back. So there is a sizable percentage that are lost to follow-up, and we do have some concern that maybe those eyes are getting worse if they don't have anti-VEGF injection. So I think pan-retinal photocoagulation still has a role, particularly for those patients that may not be highly compliant. We're also looking at the DRCR network using anti-VEGF in pre-proliferative eyes to see if we can have better outcome, and that's our protocol W. We're looking at use at wide field angiography in protocol AA. We have some non-diabetic retinopathy protocols as well. So there's going to be a lot of interesting data coming out over the next few years.